Now comes the osteochondroma. Many times, many MCQs were given in osteochondroma. Osteochondroma, otherwise some are called as exostosis. Exostosis. Osteochondroma per se, many people consider it as what is called a bony dysplasias, growth abnormalities, or what is called developmental defects, not as a tumor. Just like what I have told you already, just I will show the picture again because it is one of the very important thing. So, this is what is called the epiphyseal part developed from the epiphyseal cartilage. Now there is the growth plate. I repeat again the same thing I told you yesterday also. The growth plate is there which contains what is called various layers of cells, cartilage, proliferative, what is called calcified, acellular and matured, like that. So from the periphery, from the center, if the dysplasia is in the center, if the dysplasia is center, an enchondroma results. An enchondroma results. If the dysplasia is at the periphery, so that means one of these peripheral cells will start forming its own autonomously new bone. Bone formation, that is osteochondroma. If it is the center part, it will call chondroma, enchondroma. Just like this is an MBBS students 1, 2, 3, 4, 5. Before, after finishing metaphysics, he will be going to the doctorship. After finishing first year, second year, third year, fourth year, and fifth year, he will go to the metaphysics and then become the doctor. But this fellow wants to become a doctor in the second or third year itself and try to put up a private practice separately, like this. He wanted to start the growth cartilage from not this maturation. So it parallels with the original growth. This fellow, the same elements here are elements of bone, everything, whatever occurring here will be starting here. So there will be a bone formation is there, but it is surrounded by cartilage cap. Bone is there, but it is surrounded by cartilage cap. It starts in this growth plate area and then slowly grows away from this towards the growth of parent bone to the center, and then starts metaphysis and then progress from the metaphysis towards the diaphyseal area. It will be growing until this bone grows. As soon as this bone stops, that means as soon as the stoppage, the growth of this bone, that means parent bone, once the fusion of the epiphysis occurs, this also stops growth. So it is almost a parallel private practice by a student and the teacher, like this. So that is the occurrence. Whereas enchondroma, it starts from the central area and then grows like this one. So this one and this one both are abnormal behaviors, but it has the quality of a tumor, but it is a dysplastic growth. But both are pre-malignant conditions of chondrosarcoma. Both are pre-malignant conditions of chondrosarcoma. So this is a pouching, outward pouching, a mushroom-like pouching, a tumor-like condition on the bone, out pouching. From the failure of the normal endochondral ossification below the growth plate, failure of the normal chondral ossification below the normal endochondral ossification below the growth plate, if the dysplastic process occurs in the lateral growth plate, it results in the osteochondroma. If the dysplastic cartilage proliferates beneath the perichondrium, if it is beneath the perichondrium, like this means perichondrium means like immediately beneath the perichondrium, surrounding area. Beneath the perichondrium, it results in what is called periosteal chondroma, very rare. If dysplastic process occurs in the central of the growth plate, the resulting tumor is enchondroma. So osteochondroma, that means it is the growing age in the adolescents. It is the adolescent growing age, the growing age, for children in the growing age. That means who are taking Complan, the persons who are taking Complan age group. That is adolescent age group. And now, if you know, these are the upper end of the tibia, lower end of the femur, upper end of the humerus, lower end of the radius. They are the growing centers. They are the growing areas. You must be remembering, to the elbow I glow, from the knee I flee. That is the nutrient artery direction. Nutrient artery goes towards the elbow and flight away from the knee. The opposite are the growing centers. Opposite are the growing centers. So the growing centers. Now one word about the growing center, because now this is what is called, the two ends are there. Two ends are there. This is one end, this is other end. Both centers will contribute to the growth. Both centers will contribute to the growth. But one of these will appear earlier, starts work earlier and stops fuses later. That is one. The other center will start late and goes early, just like one of our office members. A fellow comes at 8 o'clock and goes at 6 o'clock. And another fellow comes by 11:30 and try to go by 3. This is what is happening in the society. So, what do you call? Who is the worker you call? Both will contribute to work. Both, no doubt, that second fellow also contribute to work. But whom do you call the work? He works. So, Mr. X, who comes by X and goes by 5, says he is a worker. He is a worker. Though he also contributes, though the second man also contributes, he will say he is the worker. In the same way, though both the centers contribute to the growth, we will say the growing end, which is the growing center, which contributes the more. That is what is called the growing end. So the growing ends are upper end of the tibia, lower end of the femur, that is at the knee, and upper end of the humerus, lower end of the radius, that is in the upper limb. So these are the areas which are prone for osteochondromas, because they are the active growing areas. And these are the areas where the malignancies like osteosarcoma are also occurring. So that is upper end of the tibia, lower end of the femur, upper end of the humerus, lower end of the radius. And then it starts with the metaphysis, grows away from it, goes towards the diaphysis. It contains osseous and cartilaginous materials. And then special clinical features. The osteochondroma will be having, sometimes because it is having a cartilage cap, whenever skin is there, skin comes to the, whenever anything which is causing constant friction under the skin, it develops what is called bursa. It develops bursa, just like our housemate's knee, that is in the prepatellar bursa, or student's elbow, that is at the alacron bursa, or weaver's bursa, that is what is called, and the ischial tuberosities. Wherever there is pressure, then they may develop. Where is constant frictional pressure, they develop a bursa. Because the osteochondroma will project out under the skin is stretched over it, it develops a bursa, and that bursa may infect and bursa may go inflammation, that is bursitis. And then fracture of the tumor itself, it may fracture. The fracture of the tumor can occur, that fracture of this tumor itself, not the fracture of the bone, but the fracture of the tumor itself can occur. Fracture of the tumor itself can occur. And then, because it is growing, it can cause pressure over the vital structures. It can cause pressure over the vital structures and cause neurovascular complications. Or it may mechanically block the effect of a joint because of its similar size. It may mechanically block the effect of a joint. So these are the special clinical features for this, what is called osteochondroma. X-ray, because this tumor contains most of the tumor, because the tumor contains not the bone, most of the bone, but an amount of cartilage tissue is also there. Hence, the X-ray picture will be showing only bone. Hence, the X-ray picture, the size is less than the actual size. In the X-ray, the size is less than the actual size. So, bone outgrowth at metaphysis, tumor is less than the actual size because there is a cartilaginous component. Now, what do you think? The treatment along with the periosteum. You have to remove not the bone alone, the entire, along with the periosteum overlying it, you have to remove along with the periosteum. If the periosteum you leave it, because the periosteum contains the osteogenic cells, it may recur again. So most of the time it will not cause problems, but because of its mechanical obstruction, because of its recurrent bursitis, because of its compression on the what's called the nerves and vessels, it may be required to exercise. So you will exercise after the almost, it is always preferable to wait for until the maturity and then remove it. Commonest benign tumor, if you consider it as a tumor, commonest benign tumor, it is not a true neoplasm because it grows, stops. If a neoplasm is there, it has to grow until it should continue its growth, but it stops growth, cessation of at the epiphyseal plate. As a result, it is a result of aberration in the growth plate where a few cells from the plate grow centrifugally. I have given an example that some of the students gone out of the medical college and started practice there itself in front of the medical college itself. As a result, the aberration at the growth place where a few cells of the plate grow centrifugally as a separate lump of the bone. This is, so they see the growing ends, lower end of the femur, upper end of the tibia, that is the growing ends. It is a mushroom-like protrusion, metaphyseal zone, growing away from the growth plate, growing away from the growth plate. Though the tumor originates at the growth plate, it gets left behind because when it is started, it will be on par with the original bone. It will on par with the original bone. But the original bone will be growing like this, so it has been left behind. It has been left behind. It has not coped up with the speed of the original bone. Though it started in the metaphyseal area, it is not growing along with the bone because it is a separate one. It has left behind it. The stalk and the part of the head of the tumor are made up of mature bone, but the tip is covered with the cartilage. The main stalk, the stalk, that is called the stalk. The stalk and the main part, the stalk and the main part, the stalk and the main part is made up of bone, and then there is a cartilaginous cap. That is here. The clinical presentations around the adolescents, painless swelling, usually around the knee. The other areas are around the shoulder and around the wrist. Metaphyseal, but often it comes to as far as the diaphysis. Sessile or pedunculated. They may have pedicle or may not be pedicle. That is sessile. So this is a sessile one. I told you, sessile one. Example is sessile one. Signs. What are the various signs? Except for swelling, there may not be any signs, but the signs are mostly due to complications. The signs are mostly due to complications. Because of the complications, one, pain may be, there may be pain, and there may be mechanical factors, and there may be malignancy. Pain, mechanical factors are the two important signs. One, the overlying bursitis. Because there is a bursa, the overlying bursitis, the fracture of the base of the stalk, there may be nerve compression, there will be mechanical factors at irritation on the surface of the muscle or tendon. If a tendon is growing over it, it constantly irritates it, the tendon, and may cause mechanical problems. Osseous part may become ischemic necrosis, which I am going to tell later on, a vascular necrosis of the bone. The osseous part, the bony part may sometimes suffer from the lack of blood supply and may die and may go into ischemic. Then it will cause pain, and then it may cause the malignant changes. Malignant changes. They may go into what is called osteosarcoma or chondrosarcoma. The compression of the neurovascular bundle of the limb, and then usually, suppose now there is a osteochondroma at the fibular head. At the fibular head. What is the important thing you think in the case of neurovascular compression? Yes? Yes, it is common peroneal nerve. It is the common peroneal nerve. So there is a swelling at the fibular head, and the person may be suffering from foot drop. A swelling at the fibular head, and he may be suffering from foot drop. So compression of the common peroneal nerve. That is one of the nerve. Medial epicondyle, there may be ulnar nerve palsy, like that. Irritation of the joint movement due to mechanical block. Limitation of the joint movement, due to mechanical block. The tumor may undergo malignant transformation, chondrosarcoma, and most of the time, if it is multiple, it may go into osteosarcoma. multiple osteochondromatous is one of the pre-malignant conditions of osteosarcoma, but it can go into chondrosarcoma usually. Signs suggest to the malignant transformation that is there for every bone tumor is like that only, and there is a rapid increase in the size, not only bone tumor, any tumor which is rapidly increasing size will be malignant transformation. Appearance of pain in either to painless swelling. Appearance of pain in either to painless swelling. Diagnosis made by X-ray, you can see the typical osteochondroma. You can see the typical mushrooming of osteochondroma, typical osteochondroma, mushrooming out. A bony growth made up of mature, the cortex of this bone, the cortex of the tumor as well as the cortex of the bone are continuous with each other, medulla and medulla are continuous with each other. So a mature bone made up of a bony growth made up of mature cortical bone and marrow. The cartilage cap is not visible on the X-ray because it is not calcified, hence the size appears smaller than in X-ray than in clinical appearance. Solitary osteochondroma, you have to see the pedunculated. Just for remembrance only these figures are, just for brushing what is called revision again. So that is called the orientation is away from the growth plate. See, this is growing away from the growth plate. This is a sessile, not pedunculated, sessile. It is not non-pedunculated, not peduncle, sessile. Now after removal, see the glistening osteochondroma. On the bone there is a glistening cartilage as well as a layer, that is one. Solitary osteochondroma, gross osteochondrous spessor, bone is stacked and overlaying membrane on cartilage cap. This is again cartilage cap and underlying bone with a medullary continuate cavity with the original bone. This is the microscopic structure of solitary osteochondroma. So the treatment, whenever necessary, when necessary, that means whenever there is a complication of whether benign complication or malignant complication, whenever necessary the tumor should be excised, excision should be along with the periosteum, along with the excision, along with the periosteum. Leaving it may result in the leaving a few cartilage cells if you do it, and then it may cause a recurrence. Now what is another, in the osteochondroma there is a separate entity called diaphyseal eclasis. Though osteochondroma arises from the metaphyseal area, the osteochondromas are called diaphyseal eclasia because they are appearing on the diaphysis. After the growth, they grow towards the diaphyseal area. Hence, though it is appeared as a diaphyseal eclasis, the thing they start from the metaphysis only, but they clinically they appear in the diaphyseal area. So this is the two common names for this is, it goes in the families, diaphyseal, multiple osteochondroma may be present in multiple persons in the same family. So that is an entity, very, very important, rare and hereditary disease. This is multiple exostosis or multiple osteochondromatosis. So the other names for it is external chondromatosis syndrome, multiple cartilaginous exostosis, multiple exostosis, multiple exostosis syndrome. Almost the same, almost name. These are the synonyms for this entity. It is characterized by the multiple exostosis by or bony protrusions, inherited as autosomal dominant, long bones usually affected more severely and more frequently than short bones. The malignant change is more frequent, when compared with the solitary exostosis. Approximately half of the children of an individual family may be suffering from the same disease. So this is the one which is a brushing up of this one. Adolescence starts at the metaphysis, goes towards the diaphysis. The growing ends of growing children. Growing ends of growing children. Osteochondroma is common. The other disease which is common at the growing ends of the growing children is acute osteomyelitis. Acute osteomyelitis. The other disease which is very common in the same slogan of growing ends of growing children is acute osteomyelitis. Acute osteomyelitis, because that is the highly active area and highly active person. osteochondroma. So this is starts at metaphysical like that. So this is the one which I just go through already.